Good afternoon, and thank you everyone for attending today's webinar, Being Smart About Medicare B Value-Based Purchasing, presented by Cynthia Corman of Strategic System Solutions. Please be aware that there will be a question-answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question-answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar. Again, NJMGMA would like to thank you for attending, and I will now turn things over to Cynthia.
Hi there and welcome. So there's a lot going on in Medicare B value-based purchasing, so we'll get started. Today's agenda, we'll talk about the latest on Medicare B PQRS, Physician Quality Reporting System, the role of PQRS in CMS's Value Modifier Program, the ins and outs of that program. That program is continuing in 2016 to impact 2018 revenue, and then in 2017, MIPS takes over. But we are going to talk about 2016 and the Value Modifier Program. We'll talk about resources for coming out on top of the VM program, and how PQRS and the VM program fit in the upcoming Medicare merit-based incentive payment system that was legislated under MACRA. A few disclaimers. The webinar is not legal advice. It summarizes a lot of information, a lot of very complex information. There are best practices recommendations. They are author opinion and, again, not legal advice. Medicare's VBP program has a lot of details, and be very careful about making inferences. Everybody is going to have a slightly different strategy for participating in PQRS. Strong recommendation is that you keep CMS documentation around that backs up your practice's strategy for participating in PQRS as it impacts Medicare value-based purchasing. Medicare policy changes frequently, as we all unfortunately know, so keep an eye to CMS documentation updates throughout the year. And please note this webinar does not address PQRS and Medicare VBP for accountable care organizations or the Medicare Shared Savings Program. Okay, so the latest on Medicare B PQRS. 2015 PQRS, there is still very little time to participate, but there is time to participate. You can still do for 2015 PQRS, you still have time to do EHR Direct, which means doing your meaningfully used clinical quality measures and your PQRS measures as one if your EMR vendor supports electronic submission of your meaningfully used clinical quality measures. That's a big if. The deadline for doing that is March 11th. And as far as PQRS only goes, there is still time to do a measure group even if you haven't done anything. You can still probably squeeze in doing a measure group through the registry program. The CMS deadline for doing that is the end of March, but the registry vendors have their own deadlines. I know that PQRS Wizard has a mid-March deadline, so there are registry vendors out there that will still let you squeeze in 2015 PQRS. Now, 2016, which is the the bulk of this presentation, 2016 PQRS. Most of it is like 2015 PQRS. There are changes for the registries that don't directly impact the medical practices, so we're not going to talk about those. There's also growing use. In 2016 PQRS, there's increased use of the Consumer Assessment of Healthcare Providers and Systems. That's the CAP survey. There's a specialist CAP survey for PQRS. And in 2016, it's required for groups of 100 or more PQRS eligible providers, and it's optional for groups of 25 to 99 PQRS eligible providers. This is a hint that CMS is spreading CAP surveys, which are surveys that are administered by third-party providers or surveys administered by survey vendors direct to your patients about your practice. There's growing use of CAPS. More on Medicare B PQRS, latest. The 2016 measure groups there are a few more measure groups that have been introduced since 2015, a cardiovascular prevention group, a diabetic retinopathy group, and a multiple chronic conditions measure group. And a lot of the rationale statements for the different measures in the 2016 PQRS measures list, the rationale statements have been updated. And there's always change in measure detail. So if you're expecting to have a 2016 PQRS strategy that's pretty much the same as your 2015, you still should check the detail to make sure that you're not impacted by slight changes. Also, CMS publishes release notes every year, so you could spare yourself looking at a 600-page document if you look at the release notes and just see how your specific measures or measure groups have changed. 2016 PQRS individual measures, the changes from 2015, there are about 35 new measures, quite a few specific to anesthesiology. There's been an addition of opioid monitoring, and there are new surgical measures. And again, measure detail has changed. Okay, PQRS and meaningful use. More vendors are doing EHR Direct. So EHR Direct is the way that CMS offers for medical practices to do meaningful use clinical quality measures and PQRS measures as one. That functionality is not required of certified electronic health record technology vendors. It is optional for the vendors, but more vendors are providing that. And that is a beautiful thing because it takes away the need to do any data entry for PQRS. You basically create a file when the process of submitting measures is that your software lets you create a measures file that you then upload to CMS in specific ways through the EIDM portal. So for 2016, it's looking into whether or not your EMR vendor offers this to you. Another nice thing about that option is that meaningful use comes with tools for helping clinicians do well on their clinical quality measures. The irony is that when it comes to quality measure reporting and financial impact on medical practices, the meaningful use clinical quality measures don't have an impact one way or another. It doesn't matter if you do badly on your meaningful use clinical quality measures. Nobody will see it. And probably your clinicians are doing what they're supposed to be doing, but there's a technical reason why your meaningful use clinical quality measures aren't reflecting medical practice. PQRS measures are the ones that will impact your medical practice financially through the value modifier program. So if there's a way that you can use your EHR functionality to help your clinicians do well on their PQRS measures, that's what's going to help. That's what's going to work for you financially. So more vendors are doing EHR Direct, and this is good. Another change in 2016 is on the meaningful use side. There's the beefed up specialized registries option. I believe that in New Jersey there are no specialized registries that have been identified, but I'm not certain of that. Regardless, a lot of the specialized registries double as PQRS registries. So it's it may be worth looking at that. Last update last change on PQRS 2016 over 2015 is Physician Compare. This isn't really a change, but each year basically CMS is saying they're going to publish PQRS measures on Physician Compare, and every year they get closer to doing that for more measures. In 2016, as for 2015, CMS wants practices to report quality measures, or else they will get the 2% downward PQRS adjustment 2 years out. Everything about the Medicare B value-based purchasing programs in the ambulatory space, in the medical practice space, is a 2-year lag. So your performance period for 2016 impacts your revenue for 2018. Your performance period in 2015 impacts your revenue in 2017. And this is going to be the same thing that happens under MIPS. 2017, January 1st of 2017, is the first performance period for MIPS, and it will impact revenue in 2019. So in 2016, as for 2015, report quality measures or else, you'll have a 2% downward PQRS adjustment, and then depending on your practice size, you'll also have a value modifier cut. Smaller practices, it's a 2% cut, 10 or more PQRS eligible providers will have a 4% cut. On top of this, there's the, if you don't do meaningful use of electronic health records in 2016, you will have either a 3% cut or a 4% cut in your Medicare reimbursement in 2018. The reason I say 3% or 4%, I've seen it both ways. At one point, Medicare said that they would up the meaningful use cut each year until practices, up until 5%, unless 75% of clinicians have achieved meaningful use. And so, you know, at one point, there was one CMS presentation where they said 4% was going to be the 2018 cut. I don't think they've quite figured it out yet. Okay, PQRS and the value modifier program. What is the role of PQRS in the VM program? Well, the value modifier program puts okay, PQRS goes by individual eligible provider unless your practice elects group reporting, and then PQRS goes by the group tax ID. The value modifier program always goes by group tax ID. And the way it works is CMS looks at your PQRS measures and some claims-based quality measures that are listed on this slide. And they use your practice's performance on those measures to put your practice into a quality tier. And the quality tier is your quality measure, your practice's quality measure gets compared nationally to other practices of your specialty and in some cases of your patient risk. And based on that, you get a quality tier of low, average, or high quality. And to be part of the value modifier program, at least 50% of your tax ID's PQRS eligible providers must participate in PQRS to avoid the value modifier program downward adjustment for non-participation. Basically, the PQRS measures plus these claims-based measures related to hospital admissions and readmissions are what give your practice its quality tier. Ins and outs of the value modifier program. In addition to giving your practice a quality tier assignment, CMS gives your practice a cost tier assignment, again of low, average, or high. And the metrics that CMS uses to give this assignment are cost of care for attributed patients across the care continuum. So this is the same as, so what this means is CMS attributes patients to medical practices based on primary care services. If you're a specialty practice and your patients don't see a primary care physician and you've delivered primary care services like flu shot or you know, or E&M codes, if you bill E&M codes like 99212, 99213, and your Medicare patient doesn't have a primary care physician, that patient becomes attributed to your practice. The Medicare, when we get to the resources slides, you'll see a link to quality and resource use reports. Medicare provides practices with quality and resource use reports that detail what patients are attributed to the practice. So if your cost tier assignment is a concern for you, it's worthwhile for you to make the effort, and it's a significant effort, to get your hands on your practice's quality and resource use report so you can see what patients are being attributed to your practice and why. The why part will come from your internal investigation of why patients are appearing on your patient attribution list. Okay, so cost tier assignment. These patients, your attributed patients, are the ones that that determine whether your cost of care is, or the cost of care for your patients is considered to be low, average, or high. The total per capita cost measures are what CMS looks at, and that's not just for care delivered by your practice, it's for care delivered by basically any clinician who touches your providers, your patients, any clinician who touches your patients. So that's the total per capita cost measure. And then the CMS also looks at per capita costs for beneficiaries with 4 chronic conditions: COPD, heart failure, coronary artery disease, and diabetes. Now, just because you're an orthopedic practice, that doesn't mean you won't have any patients with these conditions attributed to you. You could be. So, you know, as the financial pressure continues to go up through the value modifier program and MIPS, you could easily find that your quality and resource use report is a very good friend to look at and see where your cost of care patients are coming from. I know I'm giving you a lot of information here. I hope it's not overwhelming. Let's see. Dawn, are you still out there?
I am.
I am having trouble. My screen is not reacting to me moving forward. Oh, there we go. Okay, so now that I've frightened everybody about the value modifier program and the cost, quality and cost tiers, the next couple of slides show how the value modifier program is going to impact you. So these are the 2017 statistics for value modifier program. If you're a small practice, the good news is there's no downside. You could be high cost, low quality, and there still won't be any downward adjustments in 2017. You could be average cost, average quality, and no bonuses. So, you know, this matrix, if you look at it for a bit, will speak for itself. 10 plus PQRS eligible providers, things are a little tougher for you. If you are in the high cost, low quality category, you're looking at a 4% cut in your Medicare reimbursement in 2017. On the right, where it says the rightmost column here, where it says 4.0x, where you see these X's, the reason for that is the value modifier program is a zero net cost program to the federal government. So the amount of money that's available for bonuses depends on the amount of money that was created by cuts for the people that for the practices participating in the program. 2015 is the only year that we know what X is, because 2015 was the first year for the value modifier program. 2015 was based on 2013 performance year, and 2015 was imposed on only practices of 100 or more PQRS eligible providers. And the ones that did well under the value modifier program got a 9.89% bonus on their Medicare B reimbursement in 2015. So the bonuses can be significant. I think that something like 20% of the practices of that size got the bonus. Now, 2018. These are the matrices for 2018 based on the 2016 performance year. So there's still time to positively impact your 2018 revenue through what you do in PQRS 2016. Smaller medical practices, you're looking at the possibility of a 2% cut if you're in the low quality, high cost category. The good news is not many folks end up in that category. The way that you can see what your current status in as far as your cost tier and your quality tier goes is by looking again at your quality and resource use report. The only ones available right now are for the 2014 performance year. At the end of this year, the 2015 reports will become available. But if you look at your 2014 report, which you can access today, the cost here probably won't change all that much because the measures that are used to put entities into the cost tier have not changed. The quality tier that you see for your 2014 QRUR will change because the PQRS program has changed dramatically between 2014 and today. So don't take your 2014 quality tier too seriously, but your cost tier, is probably not a bad thing to be aware of. So these are the, this slide here can tell you the revenue impact on your practice from the value modifier program in 2016. 2016 performance year, impact 2018. Okay, resources for coming out on top of the value modifier program. As I've said, the quality and resource use reports. You can Google on QRUR cms.gov and you'll get connected to CMS information on how to access these reports. There's also a URL at the end of this presentation that tells you how to access that. Another resource for coming out on top, population health software. Population health is the buzzword these days. All those software vendors are doing population health. What that means is how to help medical practices do well on the populations that the PQRS measures are focused on. So, it's worthwhile to look at that software to see how it can help your practice. Another interesting type of software is the predictive analytics software. So, the value modifier program cost measures don't want patients to be admitted to the hospital if they have congestive heart failure, or if they have COPD, or if they have diabetes. So the predictive analytics that can look at your patient population and see, the data about your patient population and see which patients are at risk for ending up in the hospitalized could be a useful tool. Whether or not there's good software out there to support practices is a question, but it's something to keep an eye to. So what's coming in January 1st of 2017? Under the Medicare Access and Chip Reauthorization Act of 2015, one of two things will happen to with each practice. Reimbursement will be based on one of two things: either the merit-based incentive payment system, or MIPS, which we'll talk about in this presentation, or alternate payment model, reimbursement for folks who participate in an alternate payment model. And an alternate payment model example is, of course, the accountable care organizations that a lot of practices in New Jersey are either participating in or have been invited to participate in. ACOs are an APM. People who are not practices that are not participating in ACOs, you will be reimbursed based on the Medicare incentive payment, the merit-based incentive payment system under MACRA. So Medicare B reimbursement 2019 and beyond is going to be based on clinical experience and operational activity for 2017 and beyond. So remember, it's consistent under MACRA that there's this 2-year lag between performance period and reimbursement impact. So alternative one under MACRA is this merit-based incentive payment system. Under that system, practices will get payment adjustments based on whether up or down, based on how they do on 4 things. The four things are, thing number one is quality, and it's probably a PQRS type metric or PQRS type metrics that will define that. Resource use, which is the cost metrics in the value modifier program. Meaningful use, so practices will still be asked to do meaningful use, and they will be impacted by whether or not their EPs participate in meaningful use. The fourth component of MIPS is something called clinical practice improvement activities, and we don't yet know what those are, what those will be. But basically, these four components will be weighted each year to come up with a metric for adjusting a practice's revenue. And in 2017, the biggest impact will come from PQRS. I think it's a point system where each practice will get 100 points based on these four things. And 25% of the points in 2017 will come from resource use, 25% will come from meaningful use, or something like that. But 50 of those points will be coming from PQRS. So PQRS is very big. Also, there's this option to participate. There's pretty consistently an option to participate in these programs as a medical practice instead of as individual eligible providers. So something about MIPS is that MACRA requires CMS to develop and provide clinicians with a composite performance score that incorporates MIPS EP performance on each of these categories. When I read this, MIPS EP performance, that tells me that individual eligible providers are going to be looked at under MIPS. This is interpretation. This is my interpretation. So, we really don't know what MIPS is going to look like yet. But I mention this because for practices that are taking advantage of the PQRS group reporting option, that may not prepare you well for MIPS. It may or it may not. It's something to keep an eye on because it's fine to do well on the value modifier program in 2016 and 2018, but if it doesn't through strong PQRS participation, but if it doesn't prepare you for MIPS, then 2017 through 26 is going to be a different story. Okay, there's a rulemaking process that will establish the annual list of MIPS quality measures, and that will include the PQRS, VM, and MU lists. Now, this is a graphic to tell you the impact that MIPS will have on your practice financially from 2019 through 2026 and beyond. 2019, there will be a 4% spread up. There'll actually be an 8% spread in reimbursement. 4% up to a 4% cut, up to a 4% bonus to your Medicare reimbursement based on the merit-based incentive payment system. Now, again, this is just talking about the folks that do not participate in ACOs and or other alternate payment models that CMS is coming up with. This graphic just refers to MIPS, but you can see that the financial pressure will grow as the years go on for your practice to do well under value-based purchasing. A heads up, we really don't know what the clinical practice improvement activity piece of MIPS will look like. If it's like what hospitals deal with continuing quality improvement, then you don't necessarily want to do well on all your measures today, because if you do well on all your measures today, there's nowhere to improve. There's nothing to improve on. So it's just something to kind of keep in mind as you think about how you're going to address MIPS. Okay, alternative 2 under MACRA is this alternate payment model. Under MACRA, entities that participate in an APM get a straight 5% bonus from the previous year's Medicare outlays. from CMS's outlays to the practice. Presumably, it's to the practice. So if you participate in an APM, which I know very little to nothing about, you have a different setup from the MIPS program. Now, as if you're not stressed enough with all of this complex information, I'm going to share with you something that came out last week. In the middle of last year, CMS put together a consortium of payers to create the Core Quality Measures Collaborative. And the participants were CMS and AHIP. And even though several of the larger payers have recently left AHIP, they have not left the Core Quality Measures Collaborative. So there is a page on the CMS website that speaks about the Core Quality Measures Collaborative, and it's worth Googling on and looking at. I did not have time to put that URL in this presentation, but you can Google on Core Quality Measures Collaborative and be informed about what that thing is. So they have published, last week they published sets of core measures that each insurance company participating in this collaborative has said they will use for their own value-based purchasing programs. So bottom line is, for these specialties, cardio, gastro, HIV, Hep C, medical oncology, OBGYN, and orthopedics, there is each of these specialties, there's a list of measures that supposedly all of the payers together will be asking their clinicians for. For this to be applied to the PQRS program, for these lists to be applied to the PQRS program, there would have to be changes to the federal rules, and that, as we all know, is not a slow process. It's a very time-consuming process. So, you know, my money says that PQRS will not be changed in the next year, or even in the next, possibly not even in the next 2 years, but unlikely in the next year for PQRS to be changed, or for MIPS to be changed, I should say, for MIPS to be changed in time for 2017. This initiative will not impact 2016 because 2016 PQRS was regulated by the physician fee schedule rule that came out last November. So it would take an awful lot of legislation to rush everybody into these core quality measures for purposes of 2018 reimbursement. But this is worth looking at. If you're in one of these specialties, it's worth looking at the measures that are listed there, so you know what may be coming at you. Okay, best practices for PQRS participation. And now I'm talking about PQRS 2016. Pick measures your doctors, nurses, and staff care about, because nobody likes to go to work every day and do things they think are stupid. There are an awful lot of measures in there that are measures that your practice can perform well on, and you can and will also do good for your patients, and will even provide for reimbursement, you know, in terms of billable services. So, you know, there's always a temptation to just do what's easiest for PQRS, but if you can manage to look at PQRS this year with fresh eyes, if you haven't already done so, it's good to pick measures that your clinicians and your staff care about. Preparing for MIPS, if you do measure groups for PQRS, keep in mind that these will most likely not work for your practice under MIPS. They're fine to do if you look at them as an easy way to do PQRS this year so that you have time to look at MIPS, but just keep in mind that that's not what's going to get you ready for MIPS. Measure groups won't be what gets you ready for MIPS. Also, learning how meaningful use can help you do well on your quality measures is something that will serve you well. Looking at your EMR vendors' documentation for, you know, to tell you what they provide for PQRS is a best practice, because that changes year to year, and there's tremendous variation between the EMR vendors. Even the certified electronic health record technology vendors, there's tremendous variation in what they offer in terms of PQRS functionality. Something that happened in 2015, or I should say for 2015 PQRS, is for those vendors that provided the ability to do your clinical quality measures and PQRS measures together. Those EMR vendors got a kick from CMS because it was late in the year, late in 2015, where CMS changed some technical things. And so medical practices that chose that option of doing EHR direct for PQRS probably got kicked around a bit because they probably had to submit or will have to submit a couple of times. That doesn't mean the vendors were bad. That doesn't mean the option is bad. It just means that CMS made a change late in the year that nobody was happy about. Hopefully they won't do the same thing in 2016. But if you hear from colleagues, if you're thinking about doing EHR direct and you hear from other people, oh, I did that, it was horrible, it was a mess, it didn't work. Keep in mind that it might not be a bad option for 2016 anyway. Okay, best practices for PQRS participation. Create a quality improvement program in your practice because these programs, this quality measurement and quality improvement is not something going away. So if you don't already have process in your medical practice for addressing quality improvement, then now is a good time to get that started. Suggest if you're doing claims-based reporting for PQRS, which a lot of folks do, it's a good idea to get away from that because claims-based reporting was the original easiest way to participate in PQRS. But when you do claims-based reporting, you probably don't, you can't take advantage of your EMR a lot of times for streamlining data flow into PQRS measures. You may have an administrative process that is expensive because you're keying codes into claims. And you also don't have the ability with claims-based reporting unless you have specific software, unless you have some idiosyncrasies about how your information systems report on data. If you're doing claims-based reporting, it's a lot harder to see how your clinicians are doing in the course of the year. You basically submit quality measures, they go off to CMS, and that's how things work. You don't have the ability to run a report in March that tells you of your 10 clinicians, these 3 are doing well and these 7 are not, and maybe you should talk to those 7 clinicians that are not doing well and help them do better in April. And then in April you can look again if you're doing some of the other reporting options. If you're doing claims-based reporting for PQRS, it's a lot harder to see how folks are doing in the course of the year and help them do better. Last best practice for PQRS 2016, this is probably the best practice I'm listing here. Keep for yourself an audit-ready file of CMS documentation, not vendor documentation, not my documentation, CMS documentation that backs up how you're meeting the PQRS requirements. This program, as we all know at this point, is very complex and error-prone for everybody, including CMS. And one of the things they'll do is, remember, 2016 will impact your 2018 reimbursement. So at the end of 2017, CMS will come to you saying whether you passed or failed PQRS 2016. At that time, if you pull out your audit file that says, look, I did this, and this is what you said I had to do, and I did it, that's going to be the best way for CMS to know that you should not get a reimbursement cut if they've messed something up on their end as far as analyzing your data. So keep an audit-ready file of CMS documentation that backs up how you're meeting the PQRS requirements. Okay, the last few slides give you some URLs that can help you in dealing with this very challenging program. So with all that said, are there any questions?
Okay, Cynthia, I'll start with the first question, and please get your questions in, and we'll answer them in the order that they come. The first question, we are a specialist and do belong to an ACO as a specialist. Will we be paid under MACRA or APM?
Well, MACRA is the legislation that defines how Medicare pays all its clinicians. MACRA basically replaces the physician fee schedule rules, and so it's how all ambulatory clinicians are paid from 2019 through 2026, I think, and maybe even further. So that's what MACRA is. MACRA is the law that says this is how we're going to pay everybody. And MACRA stands for the Medicare Access and CHIP Reauthorization Act. Under MACRA, there are two alternatives for how clinicians will be paid. Alternative one is the APM method, the advances, which is where the ACOs fall. Alternative two is the merit-based incentive payment system, and that's the also known as MIPS. And MIPS is the thing I was talking about, where there are going to be four components of figuring out what how to adjust clinician reimbursement. I hope that answers the question.
Okay, let's move on to the next question. Can anesthesiologists use claim-based reporting even though there is only one PQRS measure that is eligible for claims-based reporting?
Well, 2016 added the measures for anesthesiology, so there will be more than one measure. I didn't look to see if the anesthesia, so the answer for 2016 is look again at the measures that are available because there's more than one. Now, clinicians that don't have, that don't, okay, 2016 PQRS, the most basic way of doing it is to report 9 measures in 3 quality domains with 1 cross-cutting measure. If an anesthesiologist does not have face-to-face encounters with the patient, they don't have to do the cross-cutting measure, because any entity that does not do face-to-face visits as defined by their billing codes does not have to do that cross-cutting measure requirement. As far as the 9 measures in 3 quality domains, if a clinical practice, if the anesthesiologists really can't find 9 measures, then they get put into what's called the MAV process, Measure Applicability Validation process. And it is possible to succeed at PQRS with less than 9 measures, but you need to understand the MAV process and look at that CMS documentation. And the MAV process does change from year to year. So again, a long answer to a short question, but unfortunately with these programs there are no short answers. So, can you ask me the question again, Dawn, just to make sure that I answered it a little bit?
Sure. Can anesthesiologists use claim-based reporting even though there is only one PQRS measure that is eligible for claim-based reporting?
Okay, so look at the 2016 measures and confirm that for claims-based reporting there is still only one measure. Each of the measures on the individual measure list, they will say whether they're part of claims-based or registry-based reporting. If you really want to do claims-based reporting and there are really, the new anesthesiology measures really don't, are not allowable under the claims-based method, then you can go through the MAV process. Whether or not you pass MAV depends on details of the MAV process. And those details are available on the CMS website.
Okay, how will CMS determine the cost element?
Let's go back to well, I don't know how they're going to do it under MIPS. I don't believe that's been published yet. We expect that, so that's for 2017 and forward. For 2016, it's based on these cost measures that CMS gets from claims data. Total per capita cost for beneficiaries with these chronic conditions compared to the national averages for beneficiaries with these conditions. Also, total per capita cost, period, for all beneficiaries attributed to your practice compared to the national. And then Medicare spending per inpatient beneficiary from 3 days prior to an inpatient episode of care to 30 days post-discharge, again compared to peers nationally. The Quality and Resource Use Report is a really good resource for understanding, the detail around this. The QRUR report will tell you, it'll show your performance. There are some really nice columns that tell you how you did in each of these metrics and what the national averages are. So it's definitely worth looking at.
Okay. As an anesthesiology practice, are we exempt from meaningful use?
I historically have been, but I don't know I don't know if that's changed this year.
I have a question about a copy of the slide presentation. Again, the presentation will be emailed to all participants upon completion of today's webinar. I'll move to the next question. If using a registry, what info is submitted to CMS and how often?
The registries submit to CMS once. Practices can submit to the registries throughout the year typically, and then when you press submit to CMS, they submit to CMS. So that's how that works.
Okay. CMS will analyze claims data to determine if at least 15 cross-cutting measures denominator eligible encounters will be associated with the individual eligible professional. How and where will they be getting this information?
I don't quite understand the question. Can you read that again?
CMS will analyze claims data to determine if at least 15 cross-cutting measures denominator eligible encounters can be associated with the individual eligible professional. How and where will they be getting this information?
I'm not familiar with that process, but one would expect that it would come from claims data.
Okay, folks, if there's no other questions, we're going to close the webinar. I'll give you a couple more seconds here just to see if any other questions pop up. Otherwise, we'll close the webinar out. I'll be sending the presentation out to all participants. And I'd like to thank Cynthia for a great webinar, and thank you all for attending. Have a great day.
Thanks, you too.